Good morning, everybody. Welcome to Medicine Grand Rounds. I'm going to leave the land acknowledgement to Dr. Brittany Dennis. So just by way of introduction, I'm Dr. Casson, Barry Casson, an internist, and you're all from the addictions group, so you all know each other, and you know Dr. Dennis better than I do. So, but just to give a little background, which I've just learned, Dr. Dennis did her PhD at Mac in Clinepe,
yeah,
and went to medical school in London, returned to Mac for her medicine residency, and came here because of, in part, I would guess, Vancouver, but most of it for the addictions training, and is now here, and it's going to give us a presentation today, as you can see, Bridging Clinical Innovation, Research and Technology through the Road to the Recovery. So, Brittany.
Thank you so much, Dr. Casson. I'm just so thrilled to be here today, and I can't thank you all enough for tuning into this presentation. This is a project that is near and dear to my heart, and just an amazing opportunity that actually drew me out from Ontario to stay here forever. So it actually wasn't for the mountains, it was definitely for Road to Recovery. And I'm going to start by acknowledging that the lands we are on today are the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. And these are the lands that the Road to Recovery Initiative have been designed and implemented on. And I want to really acknowledge the disproportionate impact the substance use crisis has had on Indigenous communities. And in light of this, the need for more unique services that address the challenges that Indigenous patients face. And with that in mind, Road to Recovery has been created in a co-leadership structure with the Indigenous Wellness and Reconciliation team here at St. Paul's Hospital and through Providence Healthcare. And I'm going to introduce you to some of the things that we are doing. I have no conflicts of interest to declare, and I am supported by a Michael Smith Health Research BC Scholar Award. Now, in this presentation today, I want to focus on three specific areas. I'm going to introduce you to the Road to Recovery model of care, give you insights into the impetus for the design of this new substance use system of care, and really go over the purpose, structure, and key components of the Road to Recovery model. Then I'm going to summarize the first year implementation findings, giving you guys some key insights and characterizing the first year cohort of patients that have come through the Road to Recovery services, specifically our inpatient withdrawal management unit here at St. Paul's Hospital. And then I'm going to go over a very innovative solution we've been working on over one of the challenges when it comes to data infrastructure. Now, I would say Vancouver boasts itself as being the land of innovation when it comes to harm reduction. I would say we are amazing at providing services for patients who use substances, and especially harm reduction services. However, when patients want to change their relationship with substances and go to treatment or access substance use services to reduce their substance use, whether it be medications, whether it be longer-term psychosocial services or bed-based recovery, this is where issues arise. And this is mainly due to the fact that our substance use system of care is incredibly fragmented and siloed. It's difficult for patients to navigate. I'm going to give you an example of a 40-year-old gentleman who has opiate use disorder who's coming into the emergency department. Let's call this gentleman John. John comes into the emergency department overnight having suffered an overdose, and he's brought in by EMS. He'd be fortunate if he comes to an emergency department in the province or country that has an addiction medicine service available, which not all emergency departments do. He'd also be fortunate if he's seeing maybe an emerge doc who's comfortable prescribing opiate agonist treatment, but this is not consistent or standard. Let's say John decides in the emergency department, he's ready for a change. This is it. He almost lost his life. He's like, I want to go to withdrawal management. I want to go to detox. I want to get my life together. Let's say in most places, and in BC, before we implemented the new Road to Recovery model of care, patients will often be given a list of different detox services, because like I said earlier, many of them are quite fragmented, siloed, a mix of private and public organizations that don't connect or talk to each other. It'll be the onus on the patient to be the one to design their care plan, call these services, maybe get a bed date, And this is something we don't do for patients who've had a cardiac arrest or have had a heart attack, anticipating that they create their own cardiac rehab plan, or a stroke patient being the one organizing their stroke rehab. But in substance use care, the onus is generally on the patient in a very chaotic and disorganized system. Now, let's say John gets a detox date. It's in 3 weeks' time. John is unhoused. He's going to go back to shelter, and God willing, he actually makes it to that detox appointment in 3 weeks' time. Now he's going to get on to, let's say, a good dose of methadone. And let's say he gets a treatment application in to go to a more longer term facility, let's say a 30 to 90-day treatment center where he's going to get, mutual self-help, group-based treatment, cognitive behavioral therapy, some counseling. However, that's 2 months away. So now again, John is going to go back to his shelter and be expected to go back to a destabilizing environment, remain abstinent until he can get to treatment. And then often this is a place where patients will cycle back, because once they relapse, they can't go to treatment. They need to go back to detox. And it's a constant cycle through the system that is not coordinated or serving for the patients with substance use disorders. Finally, God willing, he makes it to treatment. He gets through treatment. What next? John is unhoused. He might go back into the shelter system, and he might not end up in a second stage housing type model. And he might end up again falling back through these consistent and major barriers that are faced across the transition points. Now, this is exactly the reason that Road to Recovery was developed. Road to Recovery seeks to address these barriers, and it is a new model of care that wants to provide seamless, low barrier support at all stages of recovery across those transition points we just talked about, whether it be initial assessment in the emergency department, withdrawal management through detox, through stabilization, through treatment, and finally through aftercare. Now, Road to Recovery was developed through a partnership between Providence Healthcare, including our Indigenous Wellness and Reconciliation team, with co-leadership between Dr. Shona Nolan and Harmony Johnson. As well, Road to Recovery has been a brainchild between Dr. Shona Nolan, who's our division head for the Division of Addiction here, and Cheyenne Johnson, who's the executive director of the British Columbia Centre on Substance Use. And these two women got together and were able to put together a clear plan to also convince government to provide us more support. In total, Road to Recovery has initially received a $30 million donation through private philanthropic funds. In addition to that, it was matched with $60 million from the provincial government. So in total, we received $90 million to implement this new model of care. Now, Shona and Cheyenne got together with key stakeholders to really go through that pathway that I described that John went through, and really identify all the previous issues and barriers that patients were facing and outline a potential solution we could implement to be able to have a system of care that doesn't have those same gaps. And now, not to belabor the point, but I really do want to outline specifically the differences of the previous state of care, which is usually still quite a common state of substance use care across BC, as well as across the country, and what the new Road to Recovery model seeks to provide. Now, as with John's example, you can see there are multiple different programs with different entry points that patients may have to go through to be able to access substance use care, whether that's the emergency department, if they're lucky enough to have a family doctor, or whether or not they're actually already admitted to hospital and being cared for under maybe even one of your own medical services. Now, Road to Recovery seeks to coordinate the system of care better by creating a single front door, a front door to accessing the substance use system of care. And this is through Access Central, which was already existing. And the idea would be that now, let's say John is in the emergency department, or John is in a walk-in clinic, or John is at home. He can call this single phone line and be able to start to begin to coordinate his substance use care through accessing a centralized substance use service. Now, previously, there were limited access to clinical assessments. So when people would previously call Access Central, you would get an administrator, you'd get your date for your detox booking, you might get a list of resources in the community that you can go to if you need help, and that would be it. Now what we've done is we've actually taken over Access Central and implemented an actual clinical model where now it is manned or personed by physicians and nurses who actually have clinical addiction training. So now when John calls Access Central, he's speaking to a clinician, and that clinician can do a same-day clinical assessment, and they can tell John what he may need based on his treatment goals. Finally, by the previous way, patients were accessing services based on a first come, first serve model. So like the original example I gave you with John, he'd be in the emergency department and he would be given a list of different places he can call to access treatment, whether it be a private detox, public detoxes. And in this case, you'd just be given a waitlist time because you're talking to an administrator. There was no triaging criteria being implemented. Instead, by now having physicians and clinicians within the Access Central model, we're able to actually triage patients to the appropriate services through having a same-day clinical assessment. So now we're able to apply criteria to be able to better match patients to the services they need. For example, for someone like John, he'd be triaged as an urgent patient. We can see this is a gentleman who is using fentanyl. He is now overdosed. He's had a near-death event. He's now in the emergency department. This is someone who would be considered a high-priority patient. Where we have other patients who might be calling Access Central who had a relapse to alcohol. They've been drinking for 2 days. They don't actually require a withdrawal management bed yet, but maybe they require an in-person assessment at our rapid access addiction clinic. By having a physician and nurses who are trained to understand the clinical assessments for addiction, we can better triage people and use our resources more effectively. Finally, we can, instead of clients being on multiple wait lists for multiple different services, by creating that central front door, we're able to bring all the services together and create one wait list. So it's much more efficient and effective. Finally, that fragmented care journey that results in gaps in care, like those moments where John would go to detox but get sent back to shelter. John would go to treatment but get sent back to shelter. By us not having these proper transitional care beds to support people, that was fragmented and created gaps in their care journey. So now we're implementing new types of services, like creating a transitional care bed where patients can go in between different services. And then finally, in the previous model, there's often insufficient long-term support or aftercare when patients leave treatment. And this is something we wanted to create through a new aftercare service that follows patients across their journey. Now, I just kind of explained a lot to you in terms of revamping an entire system of care, but an easier way to conceptualize it may be just to think about focusing our efforts in 2 key areas, working on coordinating service delivery and increasing local treatment capacity. So, I'm going to start by telling you where we're at in terms of service coordination. So at the moment, we've created the single front door. We've leveraged Access Central, which was the existing line people would call to try and get a detox bed, and have now staffed it with clinicians who are now able to do those same-day clinical assessments. We've essentially created almost an air traffic controller system for substance use care, understanding where all the beds are and having a single organization being the ones who are actually controlling and coordinating those beds. We've created a streamlined referral pathway to regional transitional care beds and bed-based recovery services. So now we are the ones who are also being able to see where patients are going after detox and helping to coordinate that care plan. And then finally, we've already implemented our community outreach teams through our aftercare program to support across those transition points. And we are in the midst of creating a data platform to support standardization of our metrics to evaluate how substance use care is functioning, as well as to help with future surveillance. Now, where we're at with bed capacity is we are in the midst of a phased implementation of 95 new road to recovery beds across the Providence Healthcare region. So 45 beds are currently operational, and usually people think of road to recovery, they just think of the detox unit that's upstairs, but that's the thing I really wanted to belabor the point of. Road to recovery is the system of care. It's not just that detox unit. So we have opened 25 detox or withdrawal management beds within St. Paul's Hospital, and we're at the stage where we've opened those 20 transitional care beds. So we've increased treatment capacity by adding new withdrawal management beds, but we've also created new services. New services being in the sense where we have transitional care beds that never existed before to support people through those different stages of their recovery. And as well, we've actually created a withdrawal management service that's within a hospital. And this also has not existed within BC before. And the thing that's unique about bringing it into the hospital is the fact that so many patients who are receiving withdrawal management services or detox in the community frequently have their care interrupted the minute they cannot tolerate oral meds. So for example, patients are vomiting, coming off of alcohol, and they're not able to tolerate oral intake. Right when they start to need IV medications, such as diazepam, to help keep that withdrawal under control, they're going to get sent to an emergency department because we can't do IV medications within community detox settings. And what happens? They go to the emergency department, they're expected to wait 8 hours, and they frequently don't come back to detox. So that's a major issue. So within the withdrawal management setting in a hospital, we can provide intravenous medications. We can provide phenobarbital and keep them within the withdrawal management setting and not need them to go to an intensive care setting or even into they're already in a hospital setting. But frequently, patients who require phenobarbital would never be able to go to a community detox. And then other examples is we can also connect patients to important allied health services within the hospital setting. Examples being occupational therapy. Frequently, we'll have patients turned down in community of going to treatment because they have a traumatic brain injury. They're told, you do not have the cognitive capacity to attend our treatment program. Where, when they're at Road to Recovery, we can get those cognitive assessments done. We can advocate for patients by saying, no, we've had an OT assessment. We do believe they can attend this treatment program. Where these patients are unfortunately very out of luck in community at trying to organize an OT assessment and have that advocacy made for them. Now, finally, we do have more beds coming, including a 50-bed-based treatment center that is going to be opening towards the end of this year. So we will also have our own longer-term treatment beds available. And our aftercare services are already implemented. So just to give you guys a sense, in parallel to implementing this new clinical program, we've created a robust and quite comprehensive evaluation of the Road to Recovery model of care. And this includes 2 specific streams. So we have a health service evaluation, which really looks at those system level metrics of all the patients that are coming through Road to Recovery services using different data capture and storage platforms. And most of the data we are receiving is coming from Cerner. And then we've also created a observational cohort study to really get at much of those more key questions that are related to substance use outcomes within our population. Now, in terms of the health services monitoring evaluation, we have 3 sources of data. So we have program metrics such as bed capacity, wait times, self-discharge, all those types of metrics are coming in through our Cerner database. In addition to that, we've created a standardized data capture form on substance use diagnoses, as well as different important complications from substance use, such as overdose history, which is actually created and integrated within the Cerner chart that the nurses complete on admission to our unit or on intake at the Rapid Access Addiction Clinic. So we can have standardized data that's coming in about patients with substance use disorders that are seen within the model. And then finally, we've also implemented a robust quality improvement evaluation that includes surveys to healthcare staff and patients on their experiences within this new model. Now, we've also created an observational cohort study, and I'm going to go over briefly what that includes. But throughout all of this evaluation, I also want to say that there has been co-leadership with the Indigenous Wellness and Reconciliation team in the development of all of these materials, and as well as the development of research questions related to Road to Recovery to ensure that we're also addressing the needs and objectives of Indigenous communities. In addition to that, we've also involved individuals with lived and living experience. Now, in terms of the cohort study, how it works is we recruit patients that are coming into the new Road to Recovery services. We do a baseline questionnaire on these patients, really getting granular data on substance use patterns, treatment goals, quality of life, mental health symptoms. And then we look to see as well addiction treatment history. Then we do a follow-up at 12 months just to see what changes have happened over that year in terms of substance use patterns, substance use outcomes, as well as what other addiction services they've interacted with. And then finally, we get consent for data linkage to follow patients over 5 years around different health service utilization outcomes, such as emergency department visits, healthcare utilization, and death. A purposive sample of these patients are invited for qualitative interviews so we can get more in-depth, rich data on the experiences of patients coming through Road to Recovery. And these are done at baseline in 12 months. And they're we also have 3 separate supplements that have been created for the qualitative interview guides for Indigenous participants, pregnant and perinatal populations, as well as youth to really try and capture that experience. Now, you'll notice that this cohort study has no comparator group. So at the end of the study, we aren't really going to understand how road to recovery changes someone's substance use trajectory and compared to someone who's not on road to recovery. And so we had to become very creative in developing different comparator groups. So we've proposed 3 different methods that we're going to look at changes over time. One, allowing patients to essentially act as their own control. So a self-controlled study looking at specifically the health administrative data records for patients that consent for data linkage, looking at healthcare utilization patterns, substance use patterns in terms of ED visits for substance-related complications in the 5 years pre-road to recovery, as well as the 5 years post-road to recovery. And we've also designed control groups through propensity matched analysis to existing British Columbia Centre on Substance Use cohort studies, to treatment seeking patients within those cohort studies to look at differences in terms of accessing and not accessing road to recovery, and then also in comparison at a population level to Dr. Minty's provincial substance use disorder cohort. Now, for the very interesting part, the actual results. So I'm going to go over the results of the first year cohort of patients that have come through the new road to recovery withdrawal management unit in the hospital. So this specifically has to do with patients accessing the withdrawal management road to recovery services. Now let's start with just in general the types of patients we've seen. So between September 2023 and 2024, 533 patients came through the road to recovery unit. And of them, there was actually 719 admissions. And as you'll note, some patients did have multiple admissions. That's why there's more admissions than there are people. In general, we had an 83% occupancy rate based on staff beds. We had approximately 2 admissions per day, 14 admissions per week. And on average, the length of stay was 5 days with a median of 1 day wait times. Now, as patients triaged for the hospital-based withdrawal management beds were considered the most high-risk patients for complicated withdrawal, we were interested in any critical decompensation events that happened at road to recovery. And we were pleased to see that out of 719 admissions, there were only 8 code blue calls to the unit. Unsurprisingly, these were for seizures, obviously a known complication for alcohol withdrawal and actually now opioid withdrawal with all the benzos mixed into the drug supply. And in general, 5 were stable, 2 were unstable, requiring transfer off the unit. Again, these were probably quite post-ictal patients that were not stable to stay on the unit, and 1 had decreased level of consciousness. Now, a lot of folks were interested on how road to recovery would affect other services in the hospital. We're about to bring a large population of highly vulnerable patients, often who've been lost to care, lost to follow-up with complex medical comorbidities and mental health comorbidities. And folks were concerned that there would be more work, I guess, for other services in terms of us transferring off unit. And we were happy to see we actually took more patients on our unit than we transferred off our unit. So out of the admissions during the year, we actually took in 59 patients and only sent 35 out, with the majority coming from medicine, critical care, and urban health. Now, the one other beauty of having an inpatient hospital-based withdrawal management unit is being able to access subspecialty services, which can be very difficult for patients and especially mental health services. And we can see here out of the 719 admissions, 29% did receive a subspecialty consult, and unsurprisingly, the majority of which were psychiatry. We've had an amazing relationship with psychiatry. I don't know if Grant Miller's probably not here today, but huge shout out to him and his team and how amazing that they've been, and Dr. Julia Salafonte. In addition to that, not far behind, our internal medicine colleagues have been incredibly helpful. GI has actually come quite a bit. We've had a lot of patients with advanced liver disease that we've been able to arrange scopes for, and as well cardiology, general surgery, endocrinology. I don't have it reported on this list, but neurology was actually quite high. It was even above cardiology. Now, in terms of patient metrics, what were these 533 patients like? Well, the majority were men, 58% identified as men. They were a median of 38 years, and approximately 14% were under the age of 25. In general, 41% were Indigenous, and this is a highly disproportionate representation of Indigenous patients then, when you think of them representing 6% of the total provincial population, but 41% of the patients served on road to recovery. And again, really highlighting the need for Indigenous involvement in all aspects of the generation and creation of the substance use service. In terms of the mix of substance use disorders, it was about 50-50 for alcohol and opiate use disorder, as well as 27% for stimulant use disorder. Now, in terms of our cohort study, what do you want from a cohort study? Well, this isn't all the patients who came through road to recovery, it's a sample. And what we really want to see is that this sample is representative of all of the patients on road to recovery. And we can see here in the first year, we recruited 145 participants into our cohort study, representing approximately over a quarter of the patients who came through road to recovery. And in general, we can see they were quite similar in terms of age at 38 years, 15% were again under the age of 25, majority were identifying as men at 62%, again, highly disproportionate number of Indigenous patients at 34%, and the makeup of 50-50 for alcohol and opioids. Now, in terms of our cohort study, because we're not relying on Cerner data, and we're relying on questionnaire data, we get a lot of more granular information in terms of demographics. So we can see here the majority of unstable housing, between 24% if you add them together at no fixed address. We have 6% in an SRO if you would consider that stable housing, 5% at shelter, and then about 8% were either in supportive or treatment or recovery-based housing. Now, 32% had achieved high school and 17% had achieved post-secondary education. Interestingly, 61% did have a primary care doctor. It is not surprising in the sense where we do serve a high proportion of patients from the downtown east side, where there is quite a concentration of community health centers. So patients do actually have, at times, a higher access to primary care than even patients who are not in downtown east side areas. And about 40% had an addiction provider. Now, in terms of substance use outcomes of the patients coming through the unit, I'm going to focus on retention on medications for opiate use disorder, given it's one of the key and primary outcomes that we look at for OUD. I'm going to look at completion of withdrawal management and substance-related healthcare utilization. Now, in terms of retention on medications for opiate use disorder, we can see here out of our cohort, 145 patients were recruited. About 53% or 77 had an OUD diagnosis. In the 30 days following road to recovery treatment through the detox unit, 9 or 12% did not take OAT for any days during that period. 10% took it between 1 and 15 days following road to recovery, and about 8% took it between 16 and 29 days. We were really excited to see that there was actually a 70% retention on medications for opiate use disorder for patients continuously for 30 days after treatment on our road to recovery unit, which is quite higher than the provincial average, which I'll present shortly. And if we just looked at a snapshot of 30 days after road to recovery, not requiring them to be continuously on it, 81% were back on OAT, which tells us some people may have dropped off and then retaken it. Now, when we think of the provincial statistics for OAT retention, we can look to Dr. Bonin Nozick and his incredible team who are doing leading most of the provincial evaluation work for OAT retention. And here's a paper that's from his PhD student, Megan Kurtz, who's also a very smart researcher. And we can see here, looking at OAT initiation episodes within BC, the 30-day retention rate is actually around 50% for the province. So we're at about a 20% increase. Oh, sorry, I think somebody needs to mute. We're hearing something. But anyways, again, this isn't comparing apples to apples here. Obviously, looking at a province versus our road to recovery cohort is very different. We have treatment-seeking patients at road to recovery. These are patients, again, who are also in a detox unit being sent to a transitional care bed after. So we have that kind of wraparound care and support that are being provided to these folks. And although I will also say, though, these are the patients with the most severe substance use disorders in the province that are being recruited here. So there's kind of a bit of a bias in both directions. Now, in terms of what OAT was prescribed leaving road to recovery, we can see here, this is out of 68 patients. So anyone who had even filled 1 day of opiate agonist treatment is represented here. We can see 32% were on methadone, followed by 29% on Sublocade and 22% on Cadian. Much smaller amounts of patients are coming in on Suboxone at 7%, 6% on fentanyl patch, and 2% on injectable opiate agonist treatment. And in terms of any switches after leaving road to recovery, we can actually see our team did quite a good job of matching patients to the treatments that they wanted, as 93% did maintain on the same OAT that was prescribed at road to recovery. And I do want to show here I like to highlight the IO patients because it really shows that road to recovery, getting onto the unit, this isn't only an abstinence-based model. We definitely have patients who are on the injectable opioid agonist treatment programs that are in community that want to come in and go on to other treatments. It's very hard to facilitate low-dose inductions onto Suboxone in patients who are unhoused on the injectable opioid agonist treatment program. And so even if their goal is not to stop using substances, but maybe to get on a treatment that's very complicated for them to get onto in community, we can still help to facilitate that. So the idea is changing your relationship with substances, but we do not shut the door on patients who still have different goals around their substance use. And another example that I didn't highlight enough is even when patients are on the unit and decide they don't want to stay anymore, we have peers, we have Indigenous wellness liaisons, and we have members of our team that can also help facilitate getting them to the overdose prevention site on our hospital grounds. So we can ensure we're not just shutting the door when someone doesn't want to use substances, we're just matching them to the service they need at that time. Now, in terms of outcomes, patient-initiated discharges were still quite high. So they're at about 35%. It's not surprising, though, withdrawal management is a very difficult time for patients, and sometimes it will take multiple attempts before they are either ready to go through the full withdrawal management process and ready to fully change their relationship with substances. And these numbers are actually quite similar with patient-initiated discharge rates for other addiction services across Canada and the US. However, most of those papers focus on patient-initiated discharge rates for patients admitted under either medical or surgical services in hospital. There isn't as much literature around withdrawal management services. And sorry, I really need to highlight here, though, of those who initiated discharge, overwhelming number were Indigenous, so 49%, which again tells us that we still need to adapt our services further. And that's why this data is being fed back directly to our Indigenous Wellness and Reconciliation team colleagues so that we can start to adapt the services to address this. And I was just in a meeting this week where we were talking about this. And one thing we're thinking about is having Indigenous wellness liaisons on the unit during the intake process. Is there moments, while patients are on, the unit that we are missing them during moments of vulnerability? And how can we connect them to our supportive services that are meant for Indigenous patients? And then in terms of readmission to road to recovery, like I said, leaving early is not uncommon, but coming back also happens. And this is usually, again, where folks decide, I wasn't initially ready at first, but I'm ready later. And we can see in our qualitative data that I'll present shortly, readmission is not, we don't make it a shameful process, and patients actually feel comfortable coming back to the unit. So in total, we had about 23% readmitted in that year, with the majority coming in the first 30 days after leaving at about 60%. And the median number of readmissions was 1. Now, in terms of after leaving, substance-related ED presentations happened in about 17% of patients, with the majority happening in the first 30 days. I don't love relying on administrative data for this type of stuff because it doesn't capture things as well, where if a patient, let's say his pharmacy's closed and they've missed their methadone and they come to Emerge to get an emergency methadone dose, this is captured in here as essentially a substance-related ED visit. And this is always going to be a limitation of administrative data. And again, median number of presentations was 1. Now, in terms of system level outcomes, after we implemented that front door through Access Central, where we now have clinicians triaging patients across the different withdrawal management sites within Vancouver, we looked to see over time what the changes in the wait times had. And the difference here that I want to highlight is we looked at changes in wait times and we separated by category: routine wait times, patients who are triaged as high risk, and patients who are triaged as urgent. Now, those who are triaged as urgent are patients who are essentially in the emergency department in withdrawal, and if they are not admitted to our unit, they will be staying in Emerge or be admitted under medicine. So that would be considered an urgent patient. And then in terms of a high-risk patient, well, this is someone who may not be admitted at the moment, like maybe they're not actively in withdrawal, but this is someone who is very at high risk of dying. So this is someone who has opiate use disorder, who is unhoused, who is frequently presenting to the emergency department, who is not on opiate agonist treatment. This would be considered a high risk patient, or a high priority, not high urgency. Other criteria we have that does increase your priority for road to recovery does include if you are a youth, if you are pregnant, and as well as if you are Indigenous. Now, after we implemented these changes, we can see here there was initially, obviously, a lot of people did get moved to the routine list, and over time we expected that to come down. But we could see from the initial implementation, we very quickly were able to secure beds and immediate admission for patients who are considered higher urgent and the patients who are most needing of these beds at this time. And I'm happy to say our routine beds have actually now come under 10 days. So we've really started to get the triage by implementing this same-day clinical assessment and triage criteria. We've really been able to get our wait times down and get people into care faster. Now, in terms of patient-reported outcomes and qualitative insights, we actually implemented those QI surveys on the unit. We now have close to 100, but initially for the first year cohort of patients coming through, we only got 47 completed. So it's a limitation in sample size. But what we did see was, again, these surveys showed us that patients were getting in quickly. So over 80% are getting in within less than 1 or 1 to 2 days. We could see 73% said their spiritual needs were met at Road to Recovery, 84% said their withdrawal was adequately managed, and 92% said they would recommend it to a friend, family, or loved one if they were in need. And over 80% said the care was either good or excellent. In terms of respect, we really wanted to understand how they felt when they were being treated on the unit by different members of the healthcare team. And if you look here at the tealy blue and the green is either always or usually, and you can see here again, the majority felt respected across the board in terms of by our clerks, our doctors, housekeeping, Indigenous liaisons, nurses, and social workers. In terms of what patients were saying, they really highlighted the innovation and positive experiences they had in Road to Recovery. This one patient states, well, I pretty much like everything about it. They, the Road to Recovery staff, pretty much saved my life a few times now. If it wasn't for them, honestly, I'd probably die of a seizure. They take me in when nobody else would, and they're still taking me in. They're good people. They're just trying to look out for me. Another patient highlighted their successful withdrawal management, saying, I didn't feel like I would be relapsing all the time if I wasn't able to access Road to Recovery because I would not have been able to get the amount of benzos that I need. And then finally, around readmission not being shameful was something very commonly highlighted, with one patient stating, it's just a welcoming environment that's supported. You're treated like a human being who's unwell and not a problem. You're treated with dignity. You're always greeted with a smile. Like every time I come back, they're like, welcome back. It's not because I'm embarrassed to have to come back and go, I'm coming back here again, but they don't make you feel that way. Like it's great to see you. Now, the Indigenous patient experience is incredibly important to look into, especially given the high rates of self-discharge. We did administer these surveys across the board, and actually the majority of patients completing our QI surveys were Indigenous. And what we did find was that the data suggested Indigenous patients had higher rates of satisfaction with peers and social workers. They were less likely to want to leave Road to Recovery early compared to non-Indigenous patients. They are on average younger and a higher proportion female. Now, these statistics really show us how Indigenous patients felt on the unit, with the majority, 76% saying they felt comfortable, 100% saying they felt physically safe, 94% saying they had positive experiences with staff, and 88% saying that Road to Recovery helped them reach their treatment goals. Now, we also implemented QI surveys among healthcare staff working in Road to Recovery, and these were completed by 37 staff. The majority who completed the survey were nurses at 48%, who identified as women at 73%, and approximately 46% had between 1 and 5 years work experience in the field of substance use. We can see here again, there was quite a lot of satisfaction among people working in Road to Recovery, with the majority again looking at that green and bluey teal color, stating that they were satisfied with their job conditions, job training, wellness, and job hours. And the majority noting strong workplace efficiency across different processes that happen, such as intake, discharge, rounds. Now, in terms of provider quotes, we can see here that the providers really highlighted Road to Recovery's impact. I think people working in the substance use field have started to feel, pretty vulnerable, pretty burnt out over many years and just feeling like it's not working for our patients, and that's really dissatisfying. But patients or providers working within Road to Recovery reported that seeing the system work feels so gratifying, having the ability to promptly respond to a patient's request for help, and now having the means and resources to provide the support patients suffering with addiction have so desperately needed for so long is truly phenomenal. Offering multidisciplinary care was, again, one of the huge highlights of Road to Recovery. Even beyond addiction treatment, the impact of the Road to Recovery model of care has had in connecting patients to other services has been so invaluable. Coordinating overdue surgeries for the unhoused, providing an avenue for direct access to mental health services and psychiatry, as well as connecting our patients to specialist teams, including neurology and cardiology, has had a measurable impact on patients' health and quality of life. We can finally meet people where they're at and get them the support they need to succeed. Now, as with any change to a system, the minute you're starting to centralize service coordination, we're going to need broad surveillance of the current system of care, the populations affected, and what resources are available. Like I said, we're essentially creating air traffic controllers for the whole substance use system of care. But we really need a good system of data to help us support us do our tasks. And this becomes really challenging when you think of looking up a patient's chart who's accessing substance use services. When they're in the hospital, you're relying quite heavily on Cerner. You're looking at admissions to hospital, with that internist brain on. You're looking maybe at Care Connect, trying to see if they'd had admissions at other hospitals. You're not even thinking about notes related to other substance use services, such as the Rapid Access Addiction Clinic that might live in Profile EMR. When we started to really look at all the data systems we have to combine to be able to bring together a full picture for someone's substance use trajectory, it actually became quite overwhelming. And I just give you an example here. Just thinking of looking how the substance use beds are in Cerner, the VCH beds are in Profile EMR. We have Paris is another system that really provides data capture for any data that's coming through our Access Central nurses in terms of bed times and bed bookings. REDCap is where the QI data is living, and it just becomes a nightmare when you think of all these different data sources. And even if we had the same, everything was captured in Cerner, there comes an issue when there's lack of agreement over standardization. What are the key system metrics we should be looking at, and how do we measure them? What are the clinician provider metrics that are important? What are the patient reported metrics that are important? And what should the data governance structure be for this? And that's when we decided we're actually going to create our own cloud-based data storage and capture platform called RecoverNet. And this was something that was funded through the University of British Columbia's Strategic Investment Fund that Dr. Shona Nolan and I took on. And the whole goal of creating our own data capture and storage system was essentially to be able to make a space where we can bring all the data together from all these different EMRs, be able to enable real-time tracking of substance use services and access, support standardized data collection by bringing it all in, giving folks an idea and understanding their idea of what we should be measuring and how we should be measuring it, with one example being that BRAID form I talked about earlier, which is the brief admission and intake and discharge form that we've actually created into Cerner. So by having a standardized form, other hospitals could implement it, and we could also pull that into the system. Finally, it also promotes sustainable opportunities for quality improvement and really got us thinking about a data governance structure. Now, where we're at right now is we're actually generating the new product. We're working very closely with the health informatics team and software engineers here at Providence Healthcare to create this cloud-based platform. To create the product, we actually had to get into the whole tech space. I know my research coordinator, Piper, is in here right now, and Ria is in here right now, who's our research team research coordinator. Piper was helping with the RecoverNet, but essentially, we had to come together and create user stories of how people are going to access, this dashboard, this, interactive platform. What's it going to look like for nurses? Well, what will it look like for health administrators? And this was definitely something we hadn't thought about in extensive detail, but something we've been working on, as well as what is the aesthetic visualization that we'd want this platform to look like. And then finally, and this is more of the software engineer stuff, is the integration piece. How do we actually bring this data in and be able to present it in the same space? And then finally, standardizing metrics is something we've been working on for a long time, really establishing the standardized clinical treatment related and patient important outcomes that are efficient and easy for clinicians to measure, and that we would be able to implement across other health authorities, as well as developing and implementing data collection tools within our EMRs, and then really working through regional partnerships to ensure that, again, this is our idea, this is very PHC-centric, but for us to build a system of care, we're thinking about the whole province in the future. That's the vision. So we really need to think from the ground up, and we need to involve all the stakeholders from the beginning, and that was the development and creation of the Provincial Addiction Recovery Treatment and Support Network that's being co-led by Dr. Shona Nolan, as well as Ali Butler from the Ministry of Mental Health and Addiction. And this is my AI generated idea of what I would want this model to look like. But essentially, we've completed our PIA, our STRA is done, our user stories have been created and are still being adapted and refined. And our metrics, again, are actually, well, kind of completed for now, but will continue to be adapted and refined based on the experiences at Prov Arts. And I have to take a moment as well. For some reason, I actually completed this presentation far earlier than I thought I would. I'm a big talker, so I didn't have a slide in here for our data governance structure, but I do want to say, I mean, I've said it multiple times, we've been working closely with the Indigenous Wellness and Reconciliation team. And I don't know if you're aware, but when more than 20% of your data is Indigenous, that data is all Indigenous and needs to have Indigenous data stewardship. And in light of that, we've actually created an incredible data stewardship model with Harmony Johnson and her team, where any data coming out of Road to Recovery is reviewed by their team first. Any ideas for a project that is coming out of Road to Recovery goes through a data access request process and is reviewed by their team first before we are even touching that data. And that really shows our dedication to Indigenous data sovereignty, and as well as to the idea that we need to create a substance use system of care that serves this patient population, as they are, you know, hitting close to half of the patients that we're even seeing on this unit. Now, I walked you through a whole program. I showed you the previous system of care. I showed you ideas for the new system of care. We're in a phased approach. We're just beginning, and I feel like we are on, you know, we're on to something pretty amazing, because everywhere I've gotten to talk about this, it's actually quite revolutionary, the stuff that we're doing through Road to Recovery. And I'm just really proud to be a part of this team. And these are some photos of our clinical and research teams. And yeah, I'll just stop there, and I actually have time for questions somehow.
Questions will be for you. Maybe before we ask the audience, anyone online have any questions? If not, just to mention, Brittany's presented her data today was 3 grand round talks. I mean, it's quite amazing. So questions from the audience.
Yes.
Just a quick question. Well, I have 2 questions. First question is like, the transitional beds, because I know you have transitional beds, right?
Yeah.
It's like, can people who go to other detoxes besides Road to Recovery, can they have access to those beds?
Do you mean detoxes within the PHC VCH region?
Yeah.
Okay.
Like, on 2nd Avenue can be, you know, like.
Yeah, for sure. The first questions from the audience is around who can access these transitional care beds. So right now, for the Road to Recovery ones that are located at St. Paul's Hospital, they are coming through the Providence Healthcare withdrawal management beds for the TCU. But that's not to say Vancouver Coastal Health does have their own transitional care beds that they are also able to access. Mind you, I do have social workers in the audience right now, and I'm going to call on both of them just to confirm that.
Yes, that's true. Sometimes there has been a model where people support patients to VCH beds, and that's if they're not necessarily a great fit for our Providence transitional beds. So there is some sharing of beds within VCH and Providence, and I think we'll probably do more of that.
Yeah. And so, note from the audience, Sarah Rush, amazing social worker here today, I was just explaining that while we are generally sticking to the model of patients who are coming through the Road to Recovery withdrawal management beds are going to our transitional care beds, we have been flexible before working with patients from the other VCH beds. And I will say, because again, it's a centralized coordination, we even have patients who are at Vancouver Detox who need a step up to Road to Recovery. So we're in constant coordination with the VCH teams and the PHC teams, because again, there's no point in working in the silos. So if it's something that would meet the needs of a patient, it can be brought forward to the teams to discuss. Like, it's not like a in stone.
And then second part.
Yeah.
As an outreach worker, we
Yeah.
get people into detox treatments, that kind of stuff.
Yeah.
If we do manage to get a detox bed, without going through your services, it's like, do we have access to getting our clients those transitional beds as well?
So I'm trying to understand. So you're asking that if somebody uses like if they don't go to detox, can they use the transitional care beds? Is that kind of
like while they wait for detox or while they wait to get into treatment?
so definitely. So while folks are waiting to get into treatment, that is almost the main point of the transitional care beds. But if they're waiting to get into detox, we typically don't put them into the transitional care beds because folks have detoxed before they go there. That's usually the requirement because otherwise it can destabilize the patients who have detoxed.
But then when you think about it, though, it's just this is what I'm finding as an outreach worker.
Yeah.
You know, it's like there's a lot of people who get dropped through the cracks because they don't have somewhere safe to be to safely use a low barrier place where they can use to survive by using a little bit of alcohol and a little bit of drugs. You know, like, and this is something that I've been trying to come up with a plan with to present to people because that's where we lose people.
Yeah.
That's where we will always lose people is because they're like, oh, I have to go here, but I can't do drugs or I can't drink. You know, it's like, and then detox takes, like you were saying, anywhere from 2 days to potentially 2 weeks.
Yeah.
And that's where we lose a lot of people. That's where like people will either one, they die, or two, they give up. So it's like we need a place where we can access somewhere for people who can safely use
until they're going into
until they can get into
detox. And so, I mean, I absolutely hear you. I think that's a huge gap in the system. And so the question was around when you have patients who want to access treatment, they're waiting to get into treatment, they're waiting to get into detox, right? And they have a 2-week wait. Where do they go? Right? This is the moment where it's like, and again, our own service, I've definitely can think of multiple people we've lost during those weeks. And when someone finally decides to make this change, that can be very fleeting at times, right? And so you have to capture it when that passion and that, decision is there. The one thing I'll say is something that we have done in the Rapid Access Addiction Clinic quite a bit is when patients, we get a detox bed date, and if it's a week away, we try and arrange for them to get into our hub beds. And then typically we have them coming in and almost doing withdrawal management as an outpatient within the rack each day. And we have somewhere safe for them to be at night. Again, though, I'm pretty sure those hub beds you can't actively use substances in. So that can be another reason that people are kicked out of there. So again, that idea of a low barrier place where patients can use substances before they're into detox is something that this current model does not have. But I would say the goal is actually to make it so the wait time is 0. I want to get that on demand where there isn't you've decided to make the change, but sorry, it's a week away. And right now definitely for the urgent and high priority, I feel like we're there. Like we've definitely gotten there and the routine is coming down. So we're getting there, but we're going to talk about this today.
Just one thing to acknowledge.
It's
like, I was looking at the old way and then the new way. I was a part of the old way, and I was dropped through the old way. I struggled getting through things myself and getting the help that I needed. But then my best friend was going through was accessing into the new model, and she had a lot more success than I did when I was trying. So I just wanted to acknowledge that the new changes, they are helping. And they're doing really good. And that's from an outside perspective. It's like me being a part of the old way, going through the things that I went through and being dropped the way that I was. And watching my best friend go through the new way and being taken care of better than I was. I just want to applaud that. It is doing good.
Thank you so much. I really appreciate it. And thank you for sharing your story. Like sorry, online we were we've been told about someone's experiences seeing the old way and how devastating that can be, and watching one of their friends go through the new way through Road to Recovery and how it was really beneficial and helpful for them. So we're making steps in a good direction, I hope.
Any other comments or questions? Dr. Godor.
Thank you for that excellent talk. Patient-centered, efficient, it seems great, and keep at it. Yes, looking at substance use disorder in the synthetic opioid era, high morbidity and very high mortality. Are you guys collecting data on all cause mortality and morbidity within your Part 2R framework or devices for database?
Yes. So we are definitely going. Oh, sorry. Yeah, sorry. We were asked if we are collecting data, just given the highly toxic, unregulated drug supply. We're in an era of high morbidity, high mortality for substance use disorders right now. And there was a question around how we're collecting data around mortality. So through both, through the observational cohort study, we have like a robust follow-up plan as well as data linkage. So vital statistics will definitely be able to follow the mortality rate, hoping it's not going to be high, but I think we all live in an era that we can be realistic that we will have a higher mortality than we should for patients of this age group. So that's on one hand, but we're also, like I said, we're creating quite a large administrative database for all the road to recovery patients coming through, and we will be we're linking to health administrative databases, and we will be following mortality rates and hopefully coming up with plans of how we can intervene.
Would you compare it to like other sites that aren't as wraparound or have a similar workflow? Not that you-
Yeah.
Similar demographics in the lower mainland, but show that, we are alive.
So it's a really good question. So the question is, again, it comes down to the comparator group, like how are we going to actually compare if this is working? And so this is a huge issue. And as a methodologist, I struggle with this so much. So if we compare to okay, I'll start by answering first. Road to Recovery has been approved for scale up across the province, with each health authority now being secured funding to have their own Road to Recovery. So I'm hoping soon we won't even be able to compare to other health authorities because they're going to have their own Road to Recovery, but we could compare to other provinces. But the issue really comes down to the temporality. Well, one, the evolving drug supply and the drug, I guess, demographics. If you think of Ontario drug supply is very different than BC drug supply. So in Ontario, much higher rates of xylazine, BC, much higher rates of benzos, and kind of understanding what the actual characteristics of the drug supply is will be very important in determining that, because maybe we could still have high overdose rates, but maybe our drug supply is more toxic. So it's hard to make that, I guess, distinction. The other thing we could look at was pre and post implementation, but the issue there is, again, evolving drug supply. If we look at death rate between 2015 and now, each year it was going up, up, up. Not necessarily that services weren't being, promoted. There was an increase in access to harm reduction services. We made it easier to prescribe opiate agonist treatments. We expanded rapid access addiction clinics. Like we created a pharmacy plan where anyone can access this. So we essentially tried to figure out every barrier to somebody being on opiate agonist treatment, addressing it, and the death rate kept going up. But is that because our services or public health interventions are failing, or is that because the drug supply is just so toxic? And so, yeah, it's, but we have a new fentanyl czar now, so I don't know, maybe it will change.
Yes, sorry, go ahead.
I guess the question is, so I brought clients in to emergency and a couple of them that were probably meet bad state.
Yeah, bad state.
And one where the psychosis was the EPD said, yeah, this person is not well.
Mm-hmm.
As soon as they got here, the doctor said otherwise and keep them back up.
Right.
And same with the other young client, same thing. One doctor said, yeah, yes, absolutely. Well, said if you give me some time, 2 days, 2 or 3 days, let them come down, get some care, get some food, and get, I think is it floor 8? Is it floor 10? That where the
8A?
the urban?
Yeah, urban health 8A, yeah.
So, and to get some clarity, then I can get them into the recovery home or treatment center.
Mm-hmm.
So the day doctor goes, yes, absolutely, we'll support that. The night shift doctor comes in, nope, get out of here.
Discharge. Yeah.
Can you just repeat that experience?
Yeah. Oh, so the experience being described right now is about patients being brought into hospital in a bad way, like bad withdrawal, bit psychosis, being brought to 8A during the day, the doctor saying, you can have a bit of time, we'll let you like sort out, we'll get you to a recovery house, and then at night they were discharged. And the question is.
So your emergency work with your team that do the road recovery. Do they immediately say that, in those states? I can understand the doctor in emergency say, okay, we need the beds,
Mm-hmm.
But then after all that work that we did 2-3 days to get into that point,
Yeah.
coming to emergency, or maybe even longer than that.
Yeah.
And then just to say no.
No.
And then have to go all over again and have that on your head, on your mind. Am I going to lose it?
Yeah.
I just expand that just a little bit more. Thank you for bringing that up, because there is another aspect to it, and that's what you're pointing out is the system, and you're pointing out the hospital. And all of us that work in a hospital know that Saturday and Sunday are not good days to be sick. So I would expand your question and ask you, is this related to a specific day of the week, or in your experience?
No, it was in a week. It was a weekday.
Okay.
The lady with the psychosis, the BPD said, yeah, she shouldn't be out here. The doctors there otherwise. And the young man was also a weekday.
Yeah. Okay. Thank you.
And I think it captures broad system level issues with not having the right resources at the right time. So, I mean, St. Paul's is a well-resourced hospital. We have a lot of extra things other hospitals don't have. But even if you bring that patient in at 1 p.m., by the time they get seen by the emerge doc, go through the regular process, the addiction team is not there at night, right? So now they're going to wait till the morning to see the addiction team. The emergency room physicians, I think at St. Paul's, are like incredibly well knowledged in terms of addiction services and the addiction system of care, but they don't have maybe the clear knowledge of specifically the road to recovery pathways. They can't call Access Central isn't going to be open overnight. So there's going to be gaps of how we can immediately, help that specific person who's come through emerge. And I think you highlight an area that we can really focus on is how do we actually help patients coming in through emerge, and how do we avoid emerge and actually figure out if there's a way that we can help and support people that may not necessarily even need emergency services, but actually need to get into addiction services. And you also bring up another area is mental health. And I've talked a lot today about addiction and substance use services, but I have not talked about mental health services because that is something we are still working on. Sorry. Oh, sorry.
I'm sorry to interrupt, but it's 1 o'clock and yes. Well, welcome to Grand Rounds next week. Thank you.
Thank you. Well, but we're going to talk because we're going to do a tour. We have all day to talk. Oh man, what a.
Sorry to be.
Oh, that's okay. Sorry.
It's amazing.
Oh, thank you.
The data.
Oh yes, sorry. I know.
That's okay.
Yeah. I need to probably log out of my account. Let me just. Oh wow, this is really amazing. Okay.